Thank you, Colin. So our final speaker before the question and answer is Dr. Elahe Mostaghel. She's an associate member here at Fred Hutch and also associate professor at the University of Washington. She's a medical oncologist that sees primarily men with advanced prostate cancer. So she's going to give us an update about kind of where we are and where the future is with regards to therapy for metastatic disease. Elahe?
Clearly the shortest person trying to speak up here. So nice to see everyone. And so this is just a brief outline of what I'd like to talk about. So you've heard some really important things about some of the novel treatments that are coming along. So some of what I say will cover things you've heard before, but I think that's good. It'll let us focus a little bit more on the last part of my talk, which is on immunotherapy, which we really have not heard anything about. And I think it's going to be a very important component of treatments as we move into the future. So one quick slide on our current landscape of treatment, and this is something I'm sure you're all familiar with. Well, in any event, so patients have localized disease, they get their localized therapy. Once you relapse, our most common therapy now is androgen deprivation, but over a period of time that fails and we go on to these newer treatments that are new, but really we're getting more and more experience with them, and we are learning that despite there being more powerful drugs like abiraterone and enzalutamide, that they're still clearly not the magic bullet, and patients still recur, and we still need to improve our approaches. And so this treatment landscape has been divided so far in kind of a pre-chemotherapy and a post-chemotherapy space. And so before chemotherapy, the options are now things like enzalutamide or abiraterone or Provenge, the immunotherapy drug, and then typically move on to chemotherapy. And then after chemotherapy, if you have not had any of those prior treatments, you can circle back to them. And then there are some other alternatives like a newer chemotherapy drug, cabazitaxel, or the radium-223 is an option. So, and these are all drugs that we're gaining more and more experience with and are certainly useful, but they clearly leave room for improvement. And so looking towards the future, I think continuing to target the androgen receptor is really is a key aspect of our therapy. We're doing a lot better in terms of hitting this pathway, but in most patients who progress, they still progress with activity of the androgen receptor. And so there's definitely more work to be done there. Here we go. Okay, so our first treatments, let's see. I don't know if there's a pointer that works here, but anyway. So up on the upper, here we go. Okay, so our first therapies here, or the first thing to highlight is really how we do androgen deprivation. And so, as you know, our standard approach is testicular androgen deprivation. We know a lot more about the need for inhibiting adrenal androgen synthesis, and that's where the drug Zytiga has come into play. And there are a lot of efforts at essentially doing a better version of abiraterone, or a better version of Zytiga. And the potential goals for drugs like those are to be more powerful in terms of hitting the target, to be more specific in terms of where in that pathway they target, with the idea that if we can be more careful about how we inhibit steroid synthesis, we may be able to avoid using the drugs like prednisone that we have to add on to Zytiga. And so if we can inhibit steroid synthesis without inhibiting cortisol synthesis, which is upstream of steroids, we may be able to get away without having to add that layer of treatment onto patients' therapies. So that's definitely one area of improvement. And so there are several drugs that are in trials with varying levels of success. I think we're still waiting for a drug that's clearly substantially better than abiraterone, but there are possibilities. Another really important area is how well we can target the androgen receptor itself. So this is the androgen receptor, and DHT comes in, binds to the receptor then enters the nucleus and causes signaling. And so one way to prevent that from happening is if you can decrease DHT levels, but the other is if you can actually block the DHT from binding to the receptor. And so all of our current therapies, either the older ones like bicalutamide or the newer ones like enzalutamide, are directed at binding this receptor and preventing it from entering the nucleus. And so there are newer drugs in development, this one called apalutamide, or a newer one, darolutamide. And the hope here is that these are going to bind to the androgen receptor first more strongly than our current drugs. So enzalutamide clearly binds more strongly than bicalutamide, and it may be that these newer drugs are actually even more potent than enzalutamide. But another important component is that some of these newer drugs, we hope that they're going to be active against the androgen receptor, even when the androgen receptor develops certain mutations. And so we know that, that this mutation, for example, has been discovered in tumors from patients who have been treated with enzalutamide, and it occurs in this area of the receptor called the ligand binding domain, which is the drug actually binds, and it makes it so that the drug can no longer bind to that receptor. And so then the drug stops working. And so it turns out that one of these newer anti-androgens is not affected by this mutation. And so that's a goal of these newer versions, is not only to bind to the androgen receptor more strongly, but to be able to have an impact despite some of these mutations that may develop. Now, one thing that's very important here is what I've highlighted is that we're talking about the androgen binding to the ligand binding domain. And Dr. Schweitzer commented on this. The LBD, or ligand binding domain, is actually the domain where the hormones bind to the receptor. And we know that there are now certain variants that have lost this portion of the receptor. And so they don't care if androgen is around or not. They go into the nucleus and they cause the cell to progress whether or not we have hormones around. And so what would be more useful is a molecule or a drug that can target the other end of the receptor. And that's what we call this NTD, or the N-terminal domain. That's the opposite end from where the ligand binding domain lives. And it's present in what we think are probably all forms of the androgen receptor that's important. And so I think one of the more exciting approaches for prostate cancer treatment is the development of drugs that can actually target this end of the receptor. And so if we can do that effectively, then we can not only target the regular full-length receptor, but we can also target these shorter forms of the AR, these variant isoforms that are appearing to become more and more important in terms of resistance to our standard therapies. And so there are some drugs that are in phase 1 development for this right now. There's various ways to try to target this domain. Some are drugs that directly bind this domain. Others are drugs that kind of interfere with how how the AR dimerizes or binds to DNA. But nonetheless, the point is we're trying to inhibit a component or a part of the androgen receptor that we really haven't targeted before, because all of our currently approved drugs target this one end of the molecule. Okay, so the next main thing I wanted to cover was DNA repair, and that's really been talked about both by Dr. Schweitzer and now by Dr. Pritchard. And it's probably just a reflection of the fact that this we think is a really important component of what we've learned about prostate cancer, and really appears to be an effective target for treatment. That's in real time. We're now able to use this information. This is not really a future development; it's a current development. And so, repair of damaged DNA is critical. We've learned how some of these genes are important in repair of DNA damage. And so, if you're missing the genes that can repair DNA, then those tumors are that much more sensitive to drugs that target the repair of DNA. And so, it's a significant number of patients. It turns out metastatic patients have defects in this particular pathway, and so. How do we target this pathway? The platinums are an old school way of doing it. So this is a patient who had BRCA2 loss, went through kind of standard rounds of different therapy, and when he got treated with carboplatin as part of his chemotherapy regimen, had a very dramatic response. The more fancy way of inhibiting this pathway is drugs that specifically target this enzyme called PARP, which is involved in DNA repair. And so this is an example of a patient who had loss of a different DNA repair gene, but as you can see, went through all these multiple cycles of standard treatments. But when he got treated with a PARP inhibitor, Olaparib, had a very dramatic response. And so there's just two examples of kind of of what you can actually see when you treat patients who have these defects with these drugs. And you saw this slide before from Dr. Pritchard, the idea basically being that if you don't have the patients that have no response to treatment really have no expression of these, or no defects in these repair genes. So patients who have these repair defects have this nice prolonged survival curve. The patients who don't have any of these changes in the DNA of their tumor don't respond to these drugs. And so the idea of, the precision idea of finding out what is specific to your tumor and how do we treat that best. Okay, so I'll just spend the last little bit talking about immunotherapy, and I think this is not just in prostate cancer, but in almost every cancer now is becoming more and more exciting in terms of how can we control tumor development and progression. And so I think this slide is very illustrative in terms of what can we expect from immunotherapy, and what are the settings in which it is probably not appropriate to try. So This is a curve of a patient's tumor burden, and if you gave them no therapy, their cancer would simply progress, and at a certain point they would die from their tumor. Now when we use therapies like hormone therapy or chemotherapy, we can get a nice response. The PSA or the tumor burden goes down, but the relapse or the progression rate is fairly quick, and then the rate at which the tumor recurs is fairly quick. What immunotherapy does that's different is it doesn't actually cause the tumor to regress. So the tumors don't shrink on scans, your PSA doesn't go down necessarily, but what happens is it slows the overall growth rate of the tumor. So that, maybe after 3 weeks after starting treatment, you'd rather be this patient whose tumor had this nice regression. But in reality, over the long term, the immunotherapy has really put the brakes on the cancer, so that even if it hasn't physically gotten smaller, its ability to grow has really been retarded. And so in the long run, that is going to control tumor growth for a lot longer. And what we're learning now is that really it's probably the ideal approach is going to be a combination of these approaches, where you can give a drug that really knocks back the tumor and then incorporate the immunotherapy and start this curve, this low gradual slope at a lot lower rate, at a lot lower tumor burden. And that then, that really provides an opportunity, if not for a cure, at least an opportunity for patients to die of something else. And I think that's realistically what we're looking for. So as a prostate oncologist, I'm worried about your prostate cancer, not your heart disease or diabetes. Okay. So that's the promise of immunotherapy, these really highly durable responses. That didn't come out quite right, but you know what I mean. So how does immunotherapy actually work? And one way to think about it, for prostate cancer, certainly other cancers are a little bit different, but prostate cancer to a large extent is what we consider a cold tumor. And what that means is the immune system has trouble seeing that cancer, because if it can't see it, then it can't do anything about it. And so here's the person, he's got these areas of tumor, but he's got if you look at those tumor sites, that's all that's there is tumor cells. There's no immune cells in that area able to see the tumor. And it turns out that tumor cells, prostate tumor cells in particular, are very clever. They have proteins on their surface that really essentially blind them to the immune system, so the immune system can't see them. They get the tumor cell tickles the immune cell and says, "Hey, I'm not really here," and so the immune cell's fine, okay. And the goal of immunotherapy is to reverse that process, to take those tumor cells, to get rid of that factor that's blocking the ability of the immune system to see them, so that now the immune system is activated and it can eradicate these tumor cells. And so what we call that is going from a cold tumor that really provides no signals to the immune system to a hot tumor that has a lot of these activation signals that can wake up the immune system. And so how can we do that? So there's multiple different ways, but I'm going to just talk about 3 of the most promising or more developed approaches to doing this. And so probably the oldest one, certainly for prostate cancer, is this idea of vaccines. And so vaccines are, I'll show you a little bit more in more detail, but the idea is that you can provide something to the tumor environment that brings in the tumor, that brings in the immune cells and turns them on. And so that now inside this tumor, instead of just tumor cells, you have activated immune cells as well. So one way to do that is to provide vaccines that the immune system can try to use. Another is this idea of what we call checkpoint inhibition, and I'll show you another picture that describes that a little bit better. But the idea here is to turn the blinders off of the T cells, to stop them from being disguised. And then the third one is really another variant of trying to wake up the T cells, and it's trying to provide T cells, which are what the part of the immune system that can kill the tumor cells, provide T cells that are really exquisitely sensitive to the tumor. So the first slide is really on this idea of vaccines. And so this top one here is Sipuleucel T, or Provenge. That's the one that's already been approved for prostate cancer. And the goal here is really, we're not activating the T cells specifically. We are activating the cells that activate the T cells. And so a T cell, in order for it to wake up, it has to be presented with certain molecules that tell it, hey, here's a tumor cell. And so the cells that do that are what we call antigen-presenting cells. And they are the ones that bind the T cell and say, hey, here's part of a tumor, you need to become activated and fight this tumor. And so what vaccines do is they don't directly activate the T cell, they activate the ability of the immune system to activate the T cell. And so what does that mean? So for Provenge, we harvest your blood cells, the white blood cells. They get processed in the lab, and as part of that processing, pieces of tumors or proteins from tumors are actually incorporated into those cells. Those cells are then injected back into the patient, and now those cells, they are your own cells, but they actually now have pieces of tumor incorporated into them, and they can show those pieces of tumor to your T cells in a way that the tumor itself cannot. And so now your T cells are able to see the tumor in a way that they couldn't before, because what you put back into the patient is able to is visible to those T cells. So that's one approach. Another is to take a white cell or a leukocyte, these antigen-presenting cells, and it's basically a different way of bringing tumor pieces into the white cell. And so this is where they actually use viruses that encode these pieces of tumor. They infect the white cell with this virus. The virus is no longer pathogenic for people. All it produces are these tumor antigens. And so if you take a white blood cell and you infect it with this virus, now that white blood cell essentially becomes a factory for prostate cancer pieces that are now a lot easier for your own T cells to see. So whereas your T cells couldn't see your own tumor, they can very easily see this white cell that's overexpressing lots and lots of prostate cancer antigens. And so there's a phase 3 study for this agent that's completed enrollment. We're waiting for the results. The third one that there's been a lot of work on, but hasn't really panned out, certainly as a single agent, is a different way of this vaccination idea. As my understanding, is no longer under investigation for prostate, although it is for other areas. So vaccines is one way of turning on the antigen-presenting cells, which are what try to tickle the T cells. The other way is actually to try to directly turn on the T cell. So this is the T cell. This is the APC, or the antigen-presenting cell. And this is what really influences how the T cell behaves. So the T cell has all these different signals that come, and some of them are activating signals and some of them are inhibitory signals. And what we want are the activating signals. We want to promote those, and we want to inhibit the inhibitory signals. And so it turns out that these two molecules, CTLA4 and PD1, are really key components of the way T cells become inhibited. And so if something binds to CTLA4 or if it binds to PD1 on the T cell, that T cell essentially gets turned off. And so what the idea is that we can use drugs, in this case antibodies, which bind, which essentially prevent this interaction. So the same way an anti-androgen will bind to the androgen receptor and prevent testosterone from binding to the receptor, these antibodies can bind to these receptors and prevent them from being engaged. And what that does is when you shut off these inhibitory signals to the T cell can now has a much better opportunity to become activated. And so there's two approaches to doing this. One is to inhibit this interaction, the CTLA4 interaction, or the other is the PD1 interaction. And so CTLA4 inhibitors, that's a drug called ipilimumab or Yervoy. It's been in clinical trials. It's not shown activity as a single agent, but it is being studied as a combination therapy. And probably the newer kid on the block where there's a lot of excitement are drugs that inhibit this particular interaction, this PD1 interaction. And so PD1 inhibitors are antibodies that actually bind this molecule and inhibit it. PD-L1 inhibitors are drugs that bind the ligand, or whatever it is that's supposed to bind to PD1. So whether you block the interaction, the T cell end, or you block it on the other end, it doesn't matter. All you're doing is you have to interrupt that interaction. And so some examples of those drugs, pembrolizumab is a really important one, Keytruda, nivolumab. In early studies, there was one study done with nivolumab in patients with CRPC where they did not see a response as a single agent, but again, they're looking at combinations. And I'm going to show you a couple of very interesting slides looking at the combination of pembrolizumab with enzalutamide and actually showing some significant efficacy. Okay. So the third, I think, really interesting area is the idea of engineering T cells. And so what I've talked to you about so far is what are ways we can wake up the body's own T cells. Either take out some of the antigen-presenting cells and get them excited and put them back into the person, or give drugs that can actually get the T cells themselves activated. But what if you could actually just put in T cells that were actually already activated and very specific? And so that's the idea of T cell, adoptive T cell transfer. And so adoptive basically means similar to the idea with the Provenge, you take out a patient's T cells, you play with them in the lab, and then you put them back into the patient after they've become better able to see the prostate cancer cells. And one of the most interesting ways that people have come up with to do this is to actually to try to engineer the receptor on the T cell so that it can better see the prostate cancer cell. And so T cells in nature have a very specific way that they're able to see tumor cells, and it works very well, but it's not the most efficient way. Turns out that antibodies, which are produced by a different kind of cell, a B cell, are much more direct in terms of how they recognize antigens or recognize tumors. And so what they've done is they've taken the part of the B cell, of the antibody that actually binds to tumors, and they've glued that onto the part of the T cell that activates the T cell. So you have this chimeric receptor that's half of a T cell receptor, which is what is needed to activate the T cell. But the part of it that actually recognizes the tumor is from an antibody, which is a much more efficient way of recognizing an antibody. And so when this receptor now binds to a tumor via this B cell antibody part, you can translate that down and get an actual T cell response. And that matters because of the way T cells work. So let me just go back to this picture for a minute. So here's a B cell with antibodies. So you ask, well, why couldn't just this B cell come along and recognize the tumor and kill the cell? Well, B cells are not very efficient at killing cancer cells. T cells are much better at that. And so now if you take a T cell here, and here it's got this antibody epitope, or antibody portion, this recognizes the tumor cell. In this case, for prostate cancer, it's PSMA, which you've heard is a target on prostate tumor cells. When that antibody binds to that PSMA moiety, you now get the T cell receptor part being activated. And when T cells become activated, they then secrete substances that basically go out and punch holes in the tumor cells. And so B cells, the type of cells that typically have antibodies on them, can't do that. So T cell is a much better way of trying to kill a tumor cell, but a B cell or an antibody is a much better way of recognizing the tumor cell. So this chimeric approach tries to merge those two things together. So this approach is still very early, but it's shown a lot of promise in other tumors, and I think it just needs more time to show efficacy in prostate cancer. So the last thing I'm going to talk about is how can we enhance these responses. And so this is a complicated slide, or a busy slide, but what I'm really just going to focus on is this column. And the idea is what are ways that we can make the immune system better able to see tumor cells. And it turns out that if you combine immunotherapy with other approaches that we standardly use for prostate cancer, it turns out that immunotherapy has an opportunity to work much better. And so that's either ways of doing hormone suppression or ways of doing radiation therapy. So briefly, with radiation, what we think happens is that if you radiate part of a tumor, that area that you radiated dies, right? You can't irradiate all the cancer, but you can irradiate one spot. And when that cancer cell dies and it releases pieces of itself, that can synergize with whatever immune approach you're attempting to use, because immunotherapy requires essentially dead bits of tumor cells in order to properly see the tumor. And so the radiotherapy promotes that process. We have it's a little less straightforward how hormone therapy impacts the immune system and why this would enhance immunotherapy, but it's very clear that it can. So we know that Lupron alone can alter the amount of tumor cells that go into the prostate or into the prostate tumor, and there's a lot of emerging evidence that drugs like abiraterone or enzalutamide can act on the immune system completely independently of their impact on AR signaling. They have some kind of immunomodulatory properties which are just being explored now. But the bottom line is that they do something to the immune system that makes adding immune therapy work better. And so just in terms of the types of things that people anticipate we can obtain by combining these, either radiotherapy or androgen deprivation or novel methods of androgen deprivation, is you can get improved recognition of the tumor antigens. It can promote development of the T cell responses. It can importantly promote the tumors, the immune cells, the T cells, their ability to get into the tumor, and that's really what you need to fight the tumor. Is you need more tumor cells, more T cells in the tumor. So although we don't know exactly how these things happen, it does appear that they work better together. And so I just have 2 slides to finish up with that try to drive that point. These are given to me by Dr. Hagano. And so this is a patient who had metastatic CRPC, who'd actually, his PSA had started to go up while on enzalutamide. And he had a very dramatic response to Provenge. And if you remember the original graph I show you, when we give immunotherapy, we don't expect PSA to go down. We don't expect a rapid response. We expect this kind of slow growth over time. But something was different here. In the context of his having been on enzalutamide, he had a more profound response to the Sipuleucel. And so that likely has to do with the fact that his immune cells were more revved up than we anticipated, so they were actually able to kill cells instead of just kind of control growth over time. Even more dramatic, this is data from, as was the prior slide, the original data is from Julie Graff at OHSU, but they have been studying the ability of pembrolizumab, which I'll remind you is the PD-1 inhibitor. It's one of those antibodies that tries to wake up the T cell. If you give pembrolizumab to patients who are already on enzalutamide, whereas they did not see really profound responses to that class of drugs, the pembrolizumab type of drug by itself, if patients have already been on enzalutamide, they're seeing really dramatic responses. So patients whose PSAs are 70, 80, over 1,000 are getting down to these really super low levels. And that's just something we don't expect. And so do we know exactly how this is working yet? Not quite, but we certainly are seeing really dramatic results that obviously are worth pursuing and are certainly being pursued. So there are challenges to immunotherapy. As I've told you, by itself, immunotherapy doesn't cause PSA declines. We don't really see imaging changes. So unless we have these really dramatic changes where we're doing combination therapy, as we learn about immune treatments, we really need short-term kind of metrics or cell assays to tell if the immune therapy is doing something. I didn't talk about this, but there are actually risks of significant autoimmunity. Immunotherapy is nice because in general it's a lot less toxic than chemotherapy, but in the 15 or 20% of patients where the body's immune system gets revved up too much, it can actually be very, very dangerous for patients. And so we're learning how to evaluate and control for that. But I think the real take-home message is that these combinations of immunotherapy with other approaches appear to be synergistic, and I think it's probably going to be one of the most exciting and durable responses we're going to see in terms of treating prostate cancer. So thank you.